Hi, I'm Dr. Newman, gastroenterology here at Kindred Sacramento. I want to make this video to help care for feeding tubes, both nasal type feeding tubes and feeding tubes that go directly through the skin into the body. I'm going to cover several different types of feeding tubes. In broad categories, the feeding tubes that we use are tubes that go through the nose and tubes that go through the skin. There are two types of tubes basically that go through the nose. Those that go directly into the stomach and those that pass through the stomach and go into the small intestine. The tubes that we see going through the skin are of basically three different varieties. Those that go through the skin directly into the stomach, and those that go through the skin directly into the small intestine, otherwise known as jejunal feeding tubes. And then again, there's a combination tube that goes through the skin into the stomach, but then passes through the stomach down into the small intestine. Each of these have their advantages. The advantages of the tubes that go through the nose is that when they get pulled out either on purpose or inadvertently, they're easy to place. Tubes that go through the skin, as everybody knows, are a little bit more challenging in terms of replacing them if they're inadvertently removed. There are some important concepts with respect to these tubes. First of all, I'd like to cover Dobhoff tubes. Is a small intestinal feeding tube, and hopefully everybody can see me here. You'll hear the term jejunal feeding tube, duodenal feeding tube, small bowel feeding tube, but it's a small caliper tube that's designed to go through the nose. Most of them have metal at the end that give them some weight. They also typically have a guide wire that comes in the tube. It usually comes out of the package like this, letting everybody know that there is in fact a guide wire. All that guide wire does is adds rigidity to the tube so that when it's placed, we can advance it just like we advance an NG tube. But once the tube is placed, the guide wire has to come out. You can't use this tube with the guide wire still in place. You'll also hear that you never reinsert the guide wire. The reason for that is the tip of the guide wire is very, very small and it's relatively sharp, and if the guide wire is partly out and this tube is in the stomach and there's a kink in the tube, you can push the guide wire and actually have it come out the side of the tube and perforate the bowel. So if you're placing one of these and the guide wire should come out at all, this tube needs to be completely removed out of the patient's body. The guide wire then can be put back into the tube, and then you can reinsert the tube. You never want to push this guide wire back into the tube if this feeding tube is inside the patient's body anywhere, okay? The other thing that's important with these tubes is when the guide wire is removed, whether the tip of the tube is in the stomach or whether it's in the small intestine, the tube becomes very flexible. It's a very flexible, it's a comfortable tube, it's small diameter, and the reason that it's designed not only for comfort, but it allows the body's peristalsis, the intestinal peristalsis, to push this tube further down the GI tract. And that's one of the purposes of the metal at the end, the weights. The other thing is that you can see it on x-ray. That's the other purpose of this, so you can see where the tube is. So when this is in a patient's nose, if there's, I'll see if I can do this, if there's some slack, the body can actually pull it down further. On the other hand, if it's tight and secured to the nose, the body, the peristalsis can't pull this thing further. So sometimes what you'll see is we'll ask the nurses to leave a little bit of slack in the tube, if you will, and I'm exaggerating the point, to leave some slack so that the body can actually pull the tube down further into the small intestine. These things are designed to do that. They can move on their own. They can leave the stomach and go into the small intestine, or they can actually push themselves further down in the small intestine. These can be placed at the bedside. They can also be placed endoscopically, and they can also be placed by the radiologists under fluoroscopy. The benefit of the fluoroscopy and doing it with an endoscopy is that we can take the tip of this tube and either using the x-ray machine or with the camera, the endoscope in the stomach, advance the tube into the small intestine. When it's done at the bedside, you really don't have any control over where the tip of this goes. If you get it through the stomach into the small intestine, then you got really lucky. They're really designed, when placed at the bedside, to basically get it into the stomach and then let the person's peristalsis push it down into the small intestine. Okay? So again, if there's slack outside the body, or if this tube is coiled up in the stomach, that's okay, because the peristalsis of the stomach is supposed to push this thing down into the small intestine. And while we're on the subject of small caliper tubes, these things are really not designed to accept crushed pills. They will clog, and they frequently clog. They're really designed to be used with only liquids. We do crush pills and we put them through there, but we always run the risk that it's going to clog the tube. Another important point that I'd like to bring up is one of the big differences between a small bowel feeding tube and a gastric feeding tube is that with a gastric feeding tube, you can put a large volume into the stomach all at once. You can bolus feed. In the small intestine, the caliper of the small intestine is only about an inch, and you cannot put a large volume of fluid or anything into the small intestine all at once. That creates some physiologic problems that can make the patient symptomatic and can actually be dangerous, not to mention uncomfortable. So small tubes are designed for small volumes in general. They're not designed to be used for crushed pills, only liquids. And if they're in the small intestines, you can't do bolus feeding. It has to be in a drip or at least a fairly low flow rate. Probably maximum we see up to 125 cc's an hour, and that's aggressive. Any more than that and you start to run into problems. So I want to talk about a small bowel nasal feeding tube and a gastric nasal feeding tube. The primary difference between the two, obviously, is that the small bowel feeding tube is designed to go through the nose, into the esophagus, into the stomach, and through the exit door of the stomach, known as the pylorus, down into the small intestine. We call these small bowel feeding tubes, or Dobhoff tubes, jejunal feeding tubes, duodenal feeding tubes. They tend to be smaller in caliper, so they clog a lot easier. They're more difficult to place because it's got to get out of the stomach into the small intestine. They're more comfortable. They tend to be more flexible. The NG tubes are designed, the nasogastric tube, basically to go through the nose, into the esophagus, and into the stomach, and sit in the stomach. Okay, and I know that I'm stating the obvious, but just to review things. These tend to be a little bit larger in caliper. They don't get clogged as easy. You can put medicines through these. You can put thicker tube feedings through these. They're more rigid. They're more uncomfortable. They're a little bit easier to place because they're bigger and more rigid. I'm not going to spend any more time talking about the NG tube, other than to say how these things are placed in terms of the distance is very similar. And basically the rule of thumb is, come on over here, is you put the tip of the tube roughly where you think the stomach is. Can you hold that? And we're going to run it up through the nose and around the ear. Turn sideways. About like that. And where the tube is, right here on the other side of the ear, is about where you want to advance the tube to. And this is at 75 centimeters. So ideally, you'd like to get this tube down somewhere between where it is at the nose and where it is here at the ear, 55 to 75 centimeters. And so that gives you an idea when you're placing this thing down. If you only put it down to here at the nose, you're probably not going to be all the way in the stomach. So it needs to be advanced somewhere between 55 and 75 centimeters to the 75 centimeter mark. That's at the nose, okay, at the nose.